And this morning, we are going to talk a lot about Parkinson's disease, Parkinson's dementia, and Lewy body dementia. What are the differences between those? How are they diagnosed? What are risk factors? And what are the treatment options for these? And really looking at this, so you have Lewy body dementia, and that is the umbrella term. Just like you have dementia is the umbrella term, and there's about 130 different types of dementia. This is the same concept. This is an umbrella term, and you have dementia with Lewy bodies, and you have Parkinson's disease dementia. There's a few other subtypes of this type of dementia underneath this umbrella, but for today's purposes, we're just highlighting it this way. So we'll talk pretty comprehensively about both of these, as well as Parkinson's disease. So we have an understanding of, get everybody in here, what Parkinson's disease is and how it affects the brain, how it affects a whole person, really, but then also the Parkinson's dementia, what's the difference, how does that develop, does everybody get it, and then Lewy body dementia as well. So Parkinson's disease, it's a progressive neurological disorder that damages really the central nervous system. And it really, what happens is this disease affects the dopamine producing neurons in a very specific area, kind of the deep brainstem area of the brain, the substantia nigra. And this is where you see a lot of the movement changes in persons with Parkinson's disease because of where it first starts in that substantia nigra. And the neurons, those dopamine producing neurons, have a lot to do with how our coordination and our movement and our ability to move. So this Parkinson's disease is known for it. It's a movement disorder. And we really typically see that as a tremor or really slow movement, or somebody being very rigid or kind of maybe stuck in place. They can't move, or they feel like they're stuck. We've heard that described by several different people. I just feel stuck, like I can't move my body in any way that I want to. Parkinson's disease is separated into 5 different stages, and we'll kind of walk through those in a second. But 50% of these individuals will experience a hallucination, or they'll see something that's not there. Or a delusion. So they'll have a false belief about something. A lot of the times that's described as or known as a phantom boarder syndrome. So they think that there's somebody living in the house with them that's not there. It's really not there, but they think there's either somebody upstairs or there's somebody in the next room. That's pretty typical as far as a delusion might go, particularly for Parkinson's disease. And then 50% of these individuals will also develop some mild cognitive impairment. And these are changes in our cognition, memory, and thinking abilities that are noticeable, but they're not enough to affect the day-to-day living. They can still do day-to-day activities on their own and be fairly independent, but noticing some abnormal changes also. There's about 1 million Americans living with Parkinson's disease. So about 2% of those that are 65 and older. And again, tremors are the first kind of hallmark sign that we see that somebody might have Parkinson's disease, or any movement or gait changes that you might see in them. And Parkinson's disease itself is not fatal. It's the complications of this disease that are typically fatal. And life expectancy is on average about 9 years from diagnosis. And diagnosis is pretty, you catch it pretty early because of the motor movement disorders. And here's just another visual. Again, it affects the cells, those dopamine producing neurons or nerve cells in the brain, which cause tremors, poor coordination, problems with walking and movement. All races are affected. You do tend to see it more though in men, but all races are affected, and it's typically over the age of 50 that somebody gets diagnosed with Parkinson's. Some of the symptoms, again, have to do with shaking or tremors, loss of their ability to use fine motor skills, or those, like writing, zipping things up, using utensils. It becomes much more difficult. Slow blinking, some facial expressions, drooling, difficulty swallowing. Again, this all has to do with the motor movement system in the brain, controlling those muscles, within our face and our ability to swallow. And then you can see some memory loss issues, some of that mild cognitive impairment, some confusion, inability to think or problem solve as well as they used to. And depression and anxiety can be pretty high, particularly depression with Parkinson's disease, but with Parkinson's disease dementia too, and then some hallucinations you can see. You don't really see these cognitive issues in everybody with Parkinson's disease. We'll talk more about this, but if you start to see them, you don't see them till much later. So the 5 stages of Parkinson's. There's the first stage, very mild symptoms. You usually see the tremors, and it's really an inconvenience to their day-to-day activities. They can still do them, it's just really inconvenient. Maybe they're slowing down a little bit. In stage 2, you see the symptoms affect both sides of the body. So you're seeing the tremors in both hands instead of just one, or you see it in their gait, how they're walking or shuffling, or even able to hold up their posture or their body. And you're noticing it starting to take a lot longer to do those daily activities. I mean, this is getting dressed in the morning, brushing your teeth, planning out the day, just getting the day started, cooking, you name it. And then as it progresses into stage 3, you have some more, or the more severe symptoms of that balance and that coordination. So the motor movement disorders is just getting worse and worse. So it is, now those day-to-day activities, it's not just inconvenient or it's taking me longer, it's becoming extremely difficult to where sometimes I may not be able to do it on my own because of the progression of the motor movement. And then in stage 4, it's really somebody with Parkinson's shouldn't be living alone. They shouldn't be left unattended. And they will probably need help with those day-to-day activities, especially if the fine motor skills are involved. They're going to need help because that activity may just be too difficult for them to accomplish most of the time, or they're going to need help to be involved in those self-care activities or daily activities. And then in stage 5, you can have complete immobility or complete dependence on somebody physically helping you with activities. And then you start to see cognitive symptoms are typical and more severe cognitive symptoms. So there's the memory issues along with cognitive poor judgment, problem solving, thinking abilities, things like that. And you can see the images to the left here. This is just an image of those neurons that produce the dopamine that help with the movement. So on the left-hand side, upper left corner, that's a neuron that's operating well. The dopamine's being produced, fully. But on the right side, that dopamine's not, that Parkinson's is introduced. So the neuron is not producing the dopamine that it needs to function properly. And when it can't do that, the chemical changes are changed and that neuron will eventually die. And you can see that where Parkinson's disease starts is in that substantia nigra, which is really in the kind of the deep part of the brain, that deep mid, close to the brainstem part of the brain. And it affects that dopamine there as well. So here's just a sketch of a man with Parkinson's disease that has typical features that you will see. And this is just to do with just how they're able to hold themselves up. So their posture can be stooped. They might lean forward. And if they lean forward, they're going to shuffle their feet or take really short steps, almost to kind of like they don't even lift their feet up off the floor. They're just kind of shuffling along as best they can. And they don't really swing their arms like you and I swing our arms when we walk. It's they're stuck. They can't move their arms and they're leaning forward, they're shuffling their feet. And as that happens, they're much more prone to fall and they're not going to be able to catch themselves as they trip or step over themselves, right? And then you can see the trimming or the tremors in the hands, but in the face as well. You can also see a lack of facial movement. Not able to smile. It's that flat effect. You can start seeing, and again, it's the muscles in the face are being affected. And then the the hips can also, like where the arms get stuck or they're not able to swing them, they're kind of stuck by their sides. It's also kind of like the hips and the back aren't able to move either. They're stuck too. So that trunk is stuck in place, kind of like it's a cement block. Essentially, I've heard a gentleman say, I feel like a cement block around here because I'm not able to move that. I can really just shuffle my feet. And he was very cognitive, still very with it cognitively, but he said it just makes me feel so uncomfortable because I'm scared of falling, because I know I'm not going to be able to catch myself if I fall, and if I'm going to fall right on my face. So it can really affect that depression and that anxiety just to move, to get from place to place too. So Parkinson's disease dementia. This is somebody has Parkinson's, but you have a declined or a very noticeable decline in their ability to think, reason, problem solve, to where it does start to affect their day-to-day activities. So this is where you see, I mean, these are the symptoms of a dementia, progressive dementia. When it becomes someone has Parkinson's disease dementia, they don't see these cognitive issues until at least a year after a Parkinson's diagnosis, if not 2 years after that. So you were living with Parkinson's, the motor movement symptoms, for at least a year or longer. If you had developed Parkinson's disease dementia, you're not seeing those cognitive changes until at least 1 year, 2 years, 5 years down the road. About 50 to 80% of persons with Parkinson's will develop Parkinson's dementia. And really that statistic is closer to 80%, particularly as the Parkinson's disease goes along. So it may not be 1 year after they get diagnosed, but it could be 5 years. And what one institute, the Well Institute for Neuroscience, had studied, and what their estimate is it's approximately about 10 years after you've been diagnosed with Parkinson's, where most people will start to see, that 80% of people will start to see some cognitive changes. For those that live with Parkinson's for 20 years plus, they see 83% of those people develop dementia as well. And there are certain factors at the time of a Parkinson's diagnosis that can increase your risk for future dementia. And that can be the older you are, the more at risk you are for developing that Parkinson's dementia part of it. If you have greater sensitivity to the motor symptoms changes as well, so you're just seeing more tremors, or your posture, you're just having more severe symptoms from the onset. If you already have mild cognitive impairment, so again, mild cognitive impairment might be some abnormal memory loss issues or abnormal thinking abilities, but it's not so bad that it interferes with your day-to-day living. But having that already can increase your risk for a neurocognitive or progressive dementia. If they have excessive daytime sleepiness, and we'll talk more about the sleepiness here in just a few minutes, and then the presence of hallucinations in somebody that has Parkinson's, but they're also not seeing another cognitive issue there. Now, Parkinson's disease dementia is fatal, just like a progressive dementia is fatal, because eventually as the dementia progresses, it attacks all areas of the brain to where it will, if they don't pass away from something else, they will pass away from dementia. And the average life expectancy is 7 years from the development of the Parkinson's dementia, which again will be at least 1 year after a Parkinson's diagnosis. And you can see here's just some symptoms of Parkinson's dementia. A lot of these may look very similar as somebody that has a progressive dementia, like an Alzheimer's disease or a vascular dementia. But you can see the disorientation, confusion, changes in memory. With Parkinson's dementia, the memory issues are typically not what you're going to see first. You'll see the confusion, disorientation, poor concentration and judgment, the visual hallucinations, or having a hard time interpreting visual information. So the brain takes in visually what it sees around them, and sometimes it can be really hard to figure out, like, what am I looking at? My brain can't make sense of what the object it's looking at. Delusions, again, are those false beliefs, that phantom border syndrome. Changes in appetite, changes in energy levels, so they fluctuate. We're going to talk about fluctuations here in a minute. Paranoid ideas, depression, inability to apply reasoning and good judgment, changed from what they used to be able to do. Mood swings, loss of interest or apathy, and that can be separate from depression, or it can be both. And you can also see slurred or muffled speech, or somebody has really soft voice, much more so than when they used to, like they're like they can't speak any louder. Like me, I can raise my voice and get louder, but it's really soft voice to where you have to lean in to hear them, but they can't help that or speak louder. Sleep disturbances. So this can be daytime sleepiness that's excessive, or maybe even overwhelming for them. Or they have sleep disorders that happen during the night, where that can be an REM disorder, that rapid eye movement disorder, restless leg syndrome, or they can act out their dreams or nightmares. So they're very active sleepers, more so than they would have been so in the past. Higher anxiety, swallowing problems, difficulty with sequencing of tasks or activities. It's not that they can't do it, it's just the sequencing of it's getting off. Like, what do I do next? What's next in this task? And these are other symptoms outside of those motor movement, like the tremor and the shuffling of the feet and the rigidity that you might see. We don't know what causes Parkinson's disease, like why it starts to destroy those nerve cells that make that dopamine. We're not sure. But we do know as the disease progresses or becomes worse, it can start to affect parts of the brain responsible for those cognitive issues, like memory and judgment and mental functions. And this is just a good visual of the plaque buildup that can happen in somebody with Parkinson's dementia. So risk factors for Parkinson's dementia, it does happen more often in men, but it does affect both men and women. And being over 60, so at advanced age, more advanced age, you're at a higher risk. But existing mild cognitive impairment, more severe symptoms to the motor movement disorders. So you are just more rigid, more tremors than somebody else, might have less motor movement severity at the beginning. Depression and those visual hallucinations that aren't present with another cognitive order quite yet, or disorder quite yet. So diagnosing, treating Parkinson's dementias, there's really no specific treatment for Parkinson's dementia outside of treating the symptoms. Just like we treat an Alzheimer's dementia, there's no specific treatment for that or disease modifying treatment. We're treating the symptoms and creating a high quality of life with the disease. So you focus on that symptoms. There are the cholinesterase inhibitors. This is what we use for an Alzheimer's disease and other types of dementia that can help with some of the, they do better cognitively for a little bit longer. But again, we're not changing the disease. We're just helping ease the symptoms of it. They can help with visual hallucinations and some sleep changes as well. There are the Parkinson's medications that help treat the motor disorders that come along with it. However, so Parkinson's dementia and Lewy body dementia, these can be very difficult to treat with medications because, like with a Parkinson's treatment, if I'm going to use the levodopa to help treat the movement disorders of Parkinson's for my loved one that has Parkinson's dementia, you have to be careful because that particular medication to help with the motor movement disorder can aggravate hallucinations and confusion. So it can increase cognitive dysfunction in somebody that has Parkinson's dementia. So you just have to be careful. It's not, we don't want to try it by any means. We just have to be careful and be very aware of what possible side effects can happen. You can also use certain medications to help treat depression. When we're treating depression, we can just do better no matter what we're living with. And then medications to help with those sleep disorders. And that can be a prescription medication, or it can be over-the-counter melatonin that you talk to your doctor about using, but it can help to treat some of those sleep disorders. Physical, occupational, and speech therapy are really great benefit, great treatments for this disease, Parkinson's disease, Parkinson's dementia, and Lewy body dementia. They really are extremely beneficial, even if you're in the later stages of the disease. It's important to have them part of your care team throughout the whole journey. What we do really want to avoid in persons with Parkinson's dementia are antipsychotics. What we find is that persons with antipsychotics, about 60% of people have worsening Parkinson's symptoms when they're on an antipsychotic. So I might, a doctor might prescribe somebody an antipsychotic to help treat a hallucination, but there's a worsening of the Parkinson's symptoms, that motor movement disorder, that can possibly really rapidly progress the disease, or even sometimes become fatal. So it's very, we want to be very careful. So we use non-pharmacological treatments at first for any hallucinations or anything like that. which we'll talk more about here in a second. But to diagnose Parkinson's dementia, unfortunately, there's no single test that can identify this. So what doctors really do is they rely on a battery of tests. So once Parkinson's disease is diagnosed, which there are several ways to diagnose Parkinson's disease, they'll do balance tests, movement disorder tests, full family medical history, of course, all blood work about, all the blood work that you can possibly do. And they might do a brain imaging test of some sort, an MRI or a PET scan. And they also might do a lumbar puncture to look for biomarkers of the disease. So they might grab some to see if they have the Lewy bodies that are in, and we'll look at it, we'll see a picture here in a minute to see if we can capture any Lewy bodies that might be in the lumbar puncture or the vagus nerve and how it enters into the brainstem. Once you get Parkinson's diagnosed, again, the doctors are really just starting to look for and monitor for signs of a dementia. So including cognitive functions. So they'll do psychosocial testing. They might do an MMSE. So this is a mini mental state exam to get a baseline of where somebody is at cognitively, and then do that on a reoccurring basis to see if there's any change cognitively. They'll notice memory recall, they'll look at memory health, but really for Parkinson's dementia, they're just monitoring for changes in somebody cognitively. So it's helpful if somebody does get diagnosed with Parkinson's, you're already starting to do some baseline tests for a cognition or memory tests or anything like that, so we can see changes cognitively as the Parkinson's disease progresses. And again, Parkinson's dementia doesn't really happen until a year later or much longer after somebody's diagnosed with Parkinson's. So Parkinson's dementia versus Lewy body dementia, again, it's all under that umbrella term. And that umbrella term is there's the dementia with Lewy bodies, and there's the Parkinson's with dementia. Parkinson's with dementia, what we just talked about, are the cognitive changes will appear 1 year or later after the diagnosis of Parkinson's disease. Dementia with Lewy body, the cognitive changes will appear within 1 year of the onset of the Parkinsonian movement disorders. So you're going to see the movement disorder, the Parkinson's movement, along with cognitive changes within 1 year of each other. The symptoms can be similar, and our treatment for these diseases are similar as well, which we'll talk about. But Lewy body dementia is a progressive dementia. And then again, this is what's happening is the same Lewy bodies for Parkinson's disease that build up in the substantia nigra that affect the movement disorder. Those are also present in somebody with dementia with Lewy bodies or Lewy body dementia, but they're also present on the cortex of the brain. So they're present on this outer layer of the brain. So you'll see a couple of different hallmark symptoms, but that's really kind of the main diagnosing feature of a Lewy body dementia is there is these Lewy body buildups, these proteins that build up on the cortex and the substantia nigra. But with Parkinson's dementia, it just starts there, and dementia starts to develop a year or more later. So I want to show, this is just a short 3-minute video, and it's of a gentleman that has Lewy bodies. It's from the Mayo Clinic, but just to being able to hear him and his take on what it's like to live with this disease, and his wife, who's his care partner, is always beneficial.
It happened little by little. First, he would forget things, and then he'd lose track of what he was doing. Lewy body dementia took over the life of the man you're about to meet. The disease is the second most common form of dementia, Alzheimer's being the first. There is no cure, but experts at Mayo Clinic are researching Lewy body disease in hopes of improving the lives of people who struggle with it.
In hindsight, though, there were things going on before, but you think, I'm thinking he's 75, I'll be there one day. It's just part of the aging.
But the little changes Marjorie Zellers noticed in her husband Richard were early signs of Lewy body dementia.
Expressions were almost not there anymore.
Richard also developed Parkinsonism, which often accompanies a diagnosis of Lewy body dementia.
And the stiffness in walking, his gait changed tremendously.
Their lives have also changed tremendously.
Because he was a boater, tennis player, racquetball player.
Richard is not independent anymore. His symptoms are slowly getting worse.
6 months ago, I just kept thinking it's going to go back. I kept wanting it to be like it was. But it's taken a long time to realize that it's not.
In a moment of clarity, Richard describes what it's like to slowly lose function.
It's like we wrote all your information on a blackboard and just come in with an eraser and zap through it. And what's left is the problem. And the other ones are gone and then going to come back. You can try and improve on it.
And improving on it is what Dr. Tanis Furman and Dr. Dennis Dixon strive to do.
We try very hard to detect and diagnose as early as possible because our goal is to try to reduce patient suffering, improve their quality of life. And if we can increase a person's level of functioning to a higher level early on, that's an appropriate goal for us.
Dr. Furman says it's key to make sure the diagnosis is correct. You see, Lewy body disease is often misdiagnosed as Alzheimer's disease, and the two may respond differently to some medications. And because there is no cure, the disease will inevitably progress. Dr. Dixon is researching what Lewy body disease does to the brain.
So the idea is to find molecular underpinnings of the disorders that can be used for biomarkers to diagnose it accurately. And also, if we study the molecular and pathologic underpinnings of the disorder, those might lead to avenues for treatment.
The hope of new treatments to improve the lives of people like Richard Zellers. In addition to making sure the diagnosis is accurate so people can get on proper medications, Dr. Furman says it's also important to help patients and their caregivers get the support they need at home. That can ensure a better quality of life for patients and their loved ones. For Medical Edge, I'm Vivian Williams.
So my favorite thing about that is getting to hear from the gentleman living with it and his wife. But right now we're focusing on quality of life while we're trying to figure out the complex disease. How do we live well with this disease and the treatments for it? So Lewy body dementia occurs. They said the second most common type of dementia. I think now it's the third most common type. Vascular dementia has increased a little bit, so that's really the second most common type of dementia. So I've heard several different statistics. Even this morning, I was trying to pinpoint something, but I've heard anywhere between 5 to 50% of the cases. So, you know, and what tends to happen is because it is a close cousin of Alzheimer's disease, and like the video mentioned, it gets misdiagnosed quite often. A 100% accurate diagnosis for both Lewy body dementia and an Alzheimer's dementia is at autopsy. We can diagnose fairly accurately, but being able to tell you exactly what type of dementia you have is hard. And what we're also finding a lot more of is people are living with 2 different types of dementia in the same brain. So you might see the Lewy body protein buildup, but you also might see the Alzheimer's protein buildup in the same brain. And that can be very hard to diagnose, which one's more prominent or which one started first. There are about 1 million people affected by Lewy body dementia, and the lifespan is anywhere between 2 years and 20 years. But on average, it's about 7 years. Obviously, the speed of the progression varies widely. They were talking about Mr. Zellers there. It was a slow progression, but for other people, it can be a fast progression. The greatest risk factor does seem to be age, people that are 50 and older. And again, the main difference between Parkinson's dementia and Lewy body dementia is the timing and the onset of those cognitive symptoms. So Lewy bodies are found on the outer layer, the cortex, outer layer of the brain here, and deep inside the midbrain, where that substantia nigra is. Lewy bodies are also found in persons with Alzheimer's disease and Parkinson's and Down syndrome and other disorders. So it's just hard to diagnose. It's so complex. But it's, you know, any dementia. Lewy body dementia is a dementia. It's gradual and it's progression. And it will start in one area of the brain and take over most areas of the brain. But persons with Lewy body dementia experience those physical symptoms of Parkinson's with the mild tremors, the stiffness in the body, hallucinations, and then fluctuations in alertness as well. So what happens is the accumulation of this Lewy body, and that's why it's called Lewy body dementia. It's a particular type of protein, an alpha-synuclein protein that we call Lewy bodies because it was really defined by Dr. Frederick Lewy in 1912. Dr. Lewy was a contemporary of Dr. Alzheimer. So that's why we have the names of these two dementias, the doctors who found them and described them. But these particular proteins happen to be really perfectly round, kind of smooth proteins that build up within the neuron. And these, they're not supposed to be there. They damage the neuron. Those are chemical changes that happen that eventually lead to the death of that neuron, and it progresses throughout the brain. So it goes to one neuron to the next, to where all the neurons in one particular area of the brain, they're not there anymore. So you start to see those cognitive and physical changes that happen in a person. The Lewy bodies mainly are in areas involved in thinking, memory, and movement. So they are related to Parkinson's disease. Of course, aging, 60 plus, more males tend to get it. And if there is a history of people with Parkinson's disease in your family. So this looks at kind of the regions of the brain that are affected by Lewy body dementia and kind of the stages essentially. But we can see the little red dots are the brainstem, the Lewy bodies in the brainstem. The yellow dots are the cortical Lewy bodies. So these are on the cortex Lewy bodies. So you can see the red dots that build up in that midbrain brainstem. That's where you would see Parkinson's as well, because it's that substantia nigra, that deep brainstem. You start to see those motor movements and symptoms. But the yellow dots are the cortical Lewy bodies. So if you're having some protein buildups on the cortex here, you're going to see different symptoms because of that part of the brain that's being affected by the disease. So you can see some sleep and motor disturbances. You'll see the hallucinations because of the parietal lobes on the cortex here is where you're going to see some of those changes, the sleep changes, and then eventually some of the emotional and cognitive disturbances there on the right-hand side as more and more of the brain are affected and there's more and more buildup of these bodies, these Lewy bodies, toxic proteins within the brain affect more areas of the brain. And this is what Lewy bodies look like. So you can see kind of, there's the neuron, the nucleus, there's the neuron, you have the nucleus there, and then the Lewy body that develops right next to it. In the very upper left-hand corner, if you can see my cursor, see they're just perfectly round, smooth proteins. Here is another classic perfectly round proteins. The proteins that build up in somebody that has an Alzheimer's disease, those are more tangly-like. They're not perfectly round. They look more like sticks, kind of. And they're all around the neurons, whereas the Lewy body develops inside of a neuron. So the beginning symptoms that you see cognitively change are similar that you will see in somebody with Alzheimer's disease, like the memory loss, like poor judgment, thinking issues, depression, disorientation to time and place, trouble with wayfinding. So you do is, some maybe a little bit of memory, short-term memory loss, but they may not be the most prevalent cognitive issue that you see, particularly in this dementia. But you see the other things that are similar to Alzheimer's disease. But you also can see if somebody will start to have some motor movement problems of Parkinson's. And the hallucinations. And with the hallucinations of somebody with Lewy body dementia, they can be very detailed and they're able to describe them and be very well defined. And sometimes they may be even to tell you, I'm having a hallucination. But they're very well formed. Now, most of the hallucinations, what they're seeing that's not there, most of the time it's children or pets, animals or something like that, something that's not upsetting. They just are seeing something that's not really there. Very rarely are they upsetting hallucinations, particularly early on in the disease state. What you also see as a hallmark symptom of a Lewy body dementia are fluctuations in alertness and confusion. So, and this can vary, you can be very alert, very with it one day, and then the next day they've fluctuated so much that they're very confused, may not be alert to where they're at in time, or where they are as who they are as who they are, who the people are around them are. So it's a huge fluctuation, and it can be from day to day. It can be from moment to moment. It can be from hour to hour. So you just don't see those fluctuations in another type of dementia like you would in Lewy body dementia. And this can be with confusion. It can be with alertness, so being just alert and being able to respond. But it can also be with wakefulness as well. And then you can see sleep disturbances. And this can be anywhere from an rapid eye movement sleep disorder, where they have very vivid dreams or nightmares, and they act them out. And they're not able to distinguish between that dream or nightmare and what happens when they're awake. So they might confuse those dreams for reality. It can also have significant daytime sleepiness. Again, it's kind of like where it's overwhelming. It overtakes them, sleepiness. And in some people, well, about 50% of the cases, as people are starting to look back on, hindsight's 2020, they think, yeah, so my loved one had more sleepiness that was abnormal several years before we started to see motor movement disorders or other cognitive changes in somebody with, or somebody that had Lewy body dementia. And what can also happen is you have these 4 hallmark symptoms: the Parkinsonian movement disorders, the sleep disorders, the hallucinations, and the confusions and alertness, or fluctuations in alertness. These are 4 hallmark symptoms of Lewy body dementia. They can all present themselves first or differently. So it's not that somebody has some Parkinsonian movement disorders and some cognition. You might not see, you might see people have cognitive disorders or cognitive issues and sleep disorders, and then they have the Parkinson's disorders several months into the disease. So they can present, these 4 main hallmark symptoms can present in each person differently at different times. That makes sense. So that can also cause to the complications of diagnosing it too. Other symptoms that are likely to occur in somebody that has Lewy body dementia: behavioral responses to things that are going on around them. There's impulsivity. We mentioned earlier with somebody with Parkinson's disease, they're not as in control of their movements, right? How they're able to control their body or not control their movements, but also their emotions as well. And that has to do with the buildup of the proteins in the brain and where they're happening. They're just doing the best they can within each moment and how they understand it. They can have more falls, more of that delusional thinking. That restless leg syndrome is a sleep disturbance, can be a sleep disturbance disorder. Being unresponsive, and this has to do with that fluctuations in alertness, but also responsiveness or wakefulness or attention. You can see some urinary system problems fairly early on. So they might have some urinary incontinence earlier on than you might see in somebody with an Alzheimer's dementia. Having trouble swallowing earlier on as well. Again, it has to do with those motor movement disorders and what part of the brain's being affected. And then some autonomic problems. So they might faint or become dizzy, excuse me, or have some syncopes where if they get up too fast, they might black out. Or they're unable to control their heart rate and have exercise intolerance. So they can just maybe walk from here to the bathroom and have a really high heart rate. Or sweating abnormalities. So they're excessively sweating, or they don't sweat at all. If they are doing some exercise and they're not sweating at all. So again, it's difficult to diagnose this, right? It is 100% diagnosing at an autopsy. But what they are, because there's no certain thing to really look for, and all the symptoms are very similar to an Alzheimer's disease and a Parkinson's dementia, they came up with this consensus guideline that can really help with the reliability of an more accurate diagnosis. And so what that looks like is there needs to be present a cognitive decline that interferes with their normal day-to-day activities. So there's cognition issues that are interfering with day-to-day independence. And then there needs to be 2 of the following, or even 1 can indicate Lewy body dementia. So that's the fluctuating of cognition or mental illnesses. Again, it's that varying from day to day, moment to moment. It can be week to week, but really they're looking at varying from day to day, that fluctuating in alertness or whatever. A visual hallucination, again, they can be well formed. They can reoccur. The same visual hallucination can be reoccurring. And then the Parkinsonian movement disorders. So you got to have some cognitive decline that's abnormal. It interferes with their day-to-day activities, and then at least one, if not two, of these other two symptoms here listed. Also, if there's falls, again, those autonomic issues like fainting, delusions, sensitive to neuroleptic medications, or other psychiatric symptoms, they will probably diagnose a Lewy body dementia. And it all has to do with the timing of the symptoms for it. So if both cognitive and motor symptoms appear within 1 year of each other, Lewy body dementia is most likely the diagnosis or most likely the cause. If motor symptoms appear after the first of the year, or motor symptoms appear and then cognitive symptoms don't appear until after the first of the year or 2 years later, it's most likely a Parkinson's dementia. And then signs of stroke or vascular dementia will rule out any Lewy body dementia, and they can look at those through brain imaging to rule out for stroke. And of course, they'll rule out the blood test. It's a ruling out of stuff. So it's the blood test. They'll do the motor movement test, the neuropsychological testing, all of those things. And then treating for depression as well. Depression is seen a lot in Lewy body dementia and Parkinson's dementia, more so than, or depression is seen more so in Lewy body dementia than it is in Alzheimer's disease or just Parkinson's disease. These terms get confusing. This is just a chart. Again, y'all will get copies of this, but just a chart to distinguish certain characteristics between Lewy body dementia, Alzheimer's disease, and then Parkinson's dementia. So there's the initial presentation of certain symptoms, what those cognitive symptoms look like and the timing of those, motor symptoms versus psychosis symptoms like delusions or hallucinations, and the course of the disease as well. You can look at that more. Because I want to take some time to talk about the treatments for Lewy body dementia and Parkinson's dementia. The most important and probably the one that's rated the most by all doctors and therapists is diet. Diet and exercise, excuse me. Exercise probably being the first. Exercise is so important for the treatment of Parkinson's dementia, and Lewy body dementia. The movement improves blood flow, it improves coordination, it improves strength, it keeps them, we know it's progressive and they're at decline, but it keeps them stronger for a longer period of time. Even though it might become inconvenient and it might take them longer to do certain exercise, the importance of it, because it keeps them doing better for a longer period of time. Of course, therapies like, of course, physical, but speech, occupational, and music therapies or art therapies, other therapies will help them do better for a longer period of time because we're really focusing on quality of life. And then a proper diet, anti-inflammatory diet that helps them. You might have to start changing the diet early on if there's some problems with swallowing. And a speech therapist will help you with that. So there might be, you need to eat more soft foods or something like that. But the importance of keeping those therapists as part of your care team throughout the whole journey of the progression can help you with those best treatment options. And then medications. The medications that we use to treat Alzheimer's disease can be helpful for somebody with Lewy body dementia. But treatments of depression or anxiety or any other coexisting condition that they have, the better we manage those, the better the dementia will be. Again, with Lewy body dementia and Parkinson's dementia, we just have to be a good advocate and really talk to the doctor about potential side effects and just be keeping a close watch on those. There are anti-Parkinson drugs to help with the motor movement disorders. It can help in the Lewy body dementia, but it can also worsen psychotic symptoms or psychosis symptoms. It can increase the need for hallucinations or delusions. So just being wary of that. So we always want to start at the lowest dose for any of these and go up from there and go very, very slow and keep a close watch on your loved one. And then managing sleep disorders. maybe you do a sleep study to see what type, if there's a specific type of sleep disorder that they have, restless leg syndrome or sleep apnea, and you can treat that particular disorder to help them do better. There are some medications that can be very effective and very low dosage, but we want to be aware of the side effects of those. Talking to the doctor about melatonin, because melatonin is over the counter, you always want to talk to a doctor about introducing any type of medication, is particularly with these types of dementia because of the response that they can have to side effects. And then avoid long naps during the day as best you can. Exercise is going to help with this too, but limit caffeine, limit alcohol, limit foods that might cause heartburn, things like that, to help just manage and keeping a good sleep cycle, which is kind of a day-long routine. But going to bed around the same time, waking up around the same time, getting some sunlight, getting that exercise, having equal parts rest and activity throughout the day, physical, but also mental and emotional activity as well. And then for mood or behavioral issues, always want to try the non-pharmacological interventions first. This is true across the board with any dementia that we're managing or living with or treating. So this is watching the environment. How does the environment affect a person with dementia? Is it too stimulating? Is it not stimulating enough? Is there certain times of the day that there's more high stress? Can we use other therapies like light therapies, music therapy, really getting into a good routine to where there's a familiarity and we kind of train our bodies to what's happening next throughout the day. Medication review. There are some medications we might have always been on, always taken, that might interfere negatively with this type of dementia. This can be, sleep medications. I'm taking that low dose Bayer over the counter, any supplements or vitamins. I've always taken allergy medicine. All of that stuff can interfere. And then again, the antipsychotics really be very, it's kind of not a last ditch effort, but it's one of the last things we want to try. We always want to do non-pharmacological interventions first, but if we are, and you talk to the doctor and y'all are going to try the antipsychotics, really know what the side effects are, and keep a really close eye on it, and the lowest dose to start off with. Frequent assessment and monitoring of all symptoms, and as they change, keep a diary on that and talk to the doctor about it as you see them. And caregivers, because caregivers or care partners are the ones managing the decline, because you're going to have to assist not only cognitively and mentally and emotionally, but physically assist more so, particularly as the Parkinson's movement disorders kick in and they become more rigid. And we do need to help them in and out of the chair more and in and off the toilet and with eating their meals and getting them dressed. Just physically, it can be a lot more intensive and a lot more exhausting. And being skilled in the way of direction of hallucinations and confusion. Again, most hallucinations really aren't upsetting, but it's just a nice redirection. If they're not upset about it, okay, then that's good. If they are upset about it, then generally you need to change the environment. If they're scared of somebody outside, for instance, then let's close the blinds and go into another room. It's just, it's an environmental change is going to be one of the quickest and easiest ways to help with hallucination and a delusion as well. And the same thing with confusion and being wary of, are they thinking what happened in a dream or a nightmare? Are they thinking that happened in real life? And doing some good communication techniques about actively listening, validating any emotions or feelings behind the words that they're using. And then just those redirections and distractions. Animals, sweets, kids, music are really great distractions and a good thing to redirect. And using support groups. There's going to be a list of resources here in a minute, but there is a Lewy Body Dementia Association that offers specific support groups for this particular type of dementia to be a part of. There's also a lot of more resources on that website. There's a oh my gosh, I just lost it. It'll come up to me. It'll pop up in a second. but his foundation has a lot of great resources on there. The Alzheimer's Association has really great resources on their website as well. But being a part of a support group, educating yourself, learning about the research and what's going through. The Mayo Clinic has a lot of good resources on their website as well, and the research that they're doing. Just a few other quick tips for care partners. If they are having a hallucination or a delusion, again, just stay as calm as possible. And if we need to redirect them, changing the environment is the best way to do that. Or it's okay if they're okay. Limit sensory stimulation and other distractions that can be overwhelming for them. Keep to a routine, keep to a sleep schedule, and eventually you might need to start a toileting schedule as well. You know, every 2 hours, we're at least kind of training our bodies to go to the bathroom to help keep incontinence, push it off as best we can for a longer period of time. And then prioritizing self-care as a care partner. And knowing that behaviors and this kind of some psychosis that can come along with this, they're a part of the disease. It's not your loved one doing something to be difficult, or your client to be difficult or be hard. But one of our favorite sentences here is, they are not giving you a hard time, they are having a hard time. And how can we step in and help support them during those hard times instead of making it harder? So just a quick side note on Lewy body dementia and anesthesia. This is kind of the same for all dementias, but people with Lewy body dementia who receive certain anesthetics can become more confused, more delirious, and have a really sudden and significant decline in the disease. So their functional abilities, you will notice a significant decline, which they're probably not going to get better from. They may get a little bit better, but they're not going to go back to what they were before the anesthetic. So depending on the procedure, really asking about what other possible alternatives to treat this are. Are there other alternatives to general anesthesia? Can you do a spinal block or just a regional thing? Because those different types of anesthesia result in less confusion and really can, even if there's confusion post-surgery, they come out of that anesthesia fog way better than they would a general anesthesia. So here are the resource, and it's the Michael J. Fox Foundation, not Michael Jackson. That's the one. So that has really a lot of great resources. The Lewy Body Dementia Association. The Parkinsons Foundation as well has a lot on Parkinsons disease, but also Parkinsons dementia for professional care partners, family care partners, just learning more about it and how can you get connected with specific support groups. Of course, we invite you to attend our support groups. They're led by a licensed counselor, Holly Glover, and they're educational support groups, but also time to really talk about the support that's needed in being a care partner in general. Stop sharing. And I will send out the slides this afternoon, along with a copy of the recording and our upcoming programs as well that we have. And let's see, we are not providing CE credits for this program today, but the program that we're having on Wednesday, we are, and that program is from 11:30 to 12:30, and it's about communication through the stages of dementia. Are there any other questions or comments or anything from anybody? All right, well, I appreciate your time. Again, look for that follow-up email, and we hope to see you on another one of our programs. Thank y'all.